My name is Farah Dini,
And my name is Rahana Natasha, and
and
we'll
we
be
will be
your
your
moderators
moderators
for
for
this
this
afternoon.
afternoon. It's a pleasure to have all of you joining us. This webinar is organized by Department Emergency Medicine of Hospital Chancellor Tuanku Mukris. For your information, we'll also collaborated with several organizations to ensure the success of this webinar. First, we have Remote Evaluation Consultation Service, Malaysian Society of Toxinology, Special Interest Group in Clinical Toxinology, College of Emergency Physician, Academy of Medicine Malaysia, Malaysia Biodiversity Information System, National Poison Center, University Science Malaysia, and Toxinology Education Resources and Development. Enjoy.
So now, ladies and gentlemen, join me in welcoming Dr. Irene Binti Zamhud, Emergency Medicine Specialist at Hospital Councillor Tuanku Mukris, to deliver the welcoming remarks for today's webinar. So please welcome Dr. Irene.
Assalamualaikum and good afternoon to everyone. My name is Dr. Irene. Hi, I'm the head of module for medical students. A very warm welcome to all participants to this webinar on clinical toxinology season 5 episode 3. So first and foremost, I would like to express my gratitude to the organizers for inviting me to deliver this opening speech today. I commend the team for choosing clinical toxinology as the focus of today's session. This is an area that is often underestimated but highly relevant to everyday clinical practice, particularly in emergency medicine. So for medical students, early exposure to toxinology is invaluable. I hope this webinar will inspire you to think critically about how these principles are applied in real-world clinical scenarios. And I would also like to take this opportunity to sincerely thank our esteemed panelists, Dr. Anas Amri bin Hashim, Dr. Emelia Santa Maria, Dr. Kee Vooi, Dr. Yoshiro Aoki, for joining us today. We are truly privileged to learn from experts in this field. Your willingness to share your knowledge and expertise is invaluable to those listening. I want to say thank you to Professor Dr. Khaldun also for his continuous encouragement of students' participation and your dedication to become their program advisor. Your support and guidance really play a crucial role in motivating and preparing the students for their roles as future doctors. So lastly, I also want to congratulate the organizing committee and all participants for making this webinar possible. Your commitment is truly commendable, and I'm really proud of each one of you. Thank you once again, and I really look forward to the discussions ahead. That's all from me. Thank you.
All right, thank you very much, Dr. Irene, for your insightful, encouraging remarks. So your words inspire our journey towards becoming a better clinicians. Now, let's take a moment to introduce the team behind today's webinar. So this webinar is proudly organized by the Year 5 Emergency Medicine Posting Team under the guidance of Associate Professor Dr. Ahmad Khaldun Ismail, Emergency Medicine Specialist at CTM. So we're truly grateful for his invaluable guidance and support in making this session possible. Now, let's get to know our panelists for this webinar. Today, we're fortunate to have with us 4 experts who will help us explore this theme through real clinical cases. So let me introduce you one by one. So first of all, we have Dr. Anas Amri bin Hashim, emergency physician at Hospital Sultan Abdul Halim, Sungai Petani Kedah, Malaysia. Next, we have our Dr. Emelia Santa Maria, emergency physician Department of Health, American Samoa. Next, we have Dr. Kee Vooi, Consultant Emergency Department, Enteng General Hospital at Singapore. Next but not least, we have Dr. Yoshiro Aoki, Emergency Physician, Coordination Office of the Emergency Medicine and also International Response of Acute and Critical Care Center at Nagasaki University Hospital in Japan. So thank you all for being with us today. Now, Farah, I believe we can officially dive into clinical toxinology. Can you please introduce us to what clinical toxinology is all about?
Yes, sure. So next slide. All right. So clinical toxinology is a medical specialty concerned with the diagnosis, clinical assessment, and management of envenoming and poisoning caused by animals, plants, mushroom, and bacterial toxin. So what is toxin? Toxin is a poisonous substance of biological origin produced by living organisms that can cause harmful physiological effect when introduced into a living organism. Since, since envenoming and poisoning was mentioned, so what is the difference between these two? Envenoming refers to the active injection of venom into a human through a specialized delivery apparatus such as fangs, stings, spines, or nematocysts. Venom is typically induced parenterally such as subcutaneous, intramuscular, or intravascular and contains biologically active toxins designed to immobilize prey or for defense. Poisonings, on the other hand, refer to toxic effects following exposure to a poison that is passively encountered without an injection mechanism. The toxin usually enters the body via injection, inhalation, or absorption through skin or mucosa.
All right, so before we go further, I'd like to clarify something, which is an important concept that's often misunderstood, which is the difference between venomous and also hazard level. So basically, an organism that's equipped with venom is called a venomous animal. So what defines a venomous animal is not how dangerous it is to humans, but the fact that it actively uses venom, either for prey capture or even defense. Now, the effect of venom on humans depends on several factors actually. Most importantly, it depends on the potency of the venom and the dose of the venom that actually enters the body. Because of this, the clinical severity of envenoming can range widely from potentially deadly, dangerous, or not dangerous and even harmless. So this leads to an important takeaway. So an animal is either venomous or non-venomous. There's no scientifically meaningful category in between. Terms such as highly venomous, moderately venomous, or even mildly venomous animals are not accurate descriptors. So they tend to confuse this concept of venom delivery with clinical hazard. So instead, what we should be discussing is the hazard level to humans, which is influenced by the venom dose, route of the exposure, and also the circumstances of the encounter, not whether the animal is more or less venomous. So, before this webinar, we actually conducted a survey among 44 final year amazing medical students in the current emergency medicine posting to UKM to assess their awareness and also confidence level. So based on the survey, almost half of the respondents claim that they are aware. I think this might have something to do with us joining episode 1 and episode 2, conducted by our peers a few months ago.
Alright, so in this section, we can compare the response from the previous sets of respondents for episode 1 and episode 2 with the current set of respondents for episode 3. For each segment, the upper row represents data for episode 3, the middle row represents data for episode 2, and the lower row represents data for episode 1. For confidence in providing information on appropriate safety and health-seeking behavior regarding toxic injuries, the majority of the current respondents reported feeling neutral about two components, which are toxin-related injuries as a medical emergency and various emergency services for toxin injuries. Compared to previous episode, respondents reported feeling unsure about these two components together with the role of the RECS components. As for the appropriate healthcare facilities after toxin injury, the majority of the respondents remain neutral and confident about it. Next, for the confidence in sharing knowledge on appropriate safety and health-seeking behavior for toxin injury, almost half of the respondents felt neutral about identifying the common signs and symptoms of toxin-related diseases, the appropriate first aid measures for acute exposure to natural toxin, and the various sources of natural toxin. However, respondents felt unsure about the two other components, which are emergency hotlines, guidelines, and resources for managing toxin-related disease, and appropriate antivenoms for treating envenoming in Malaysia. Looking at the previous episode, the trend was quite similar as these were also the components that respondents felt unusual about.
Thank you, Farah. And lastly, for confidence level in providing instructions or information for the toxin-related injuries, majority of the respondents felt unsure about three components, which are actually administering the appropriate first aid for toxin-related injuries, emergency procedures in cases of suspected toxin exposure, and also where patients should be transported after a toxin injury. However, for the other two components, namely identifying potential toxin injuries, obtaining important history details following a toxin injury, majority of the respondents felt neutral about them. So, from this survey, we gather greater emphasis on the role of various emergency resource and services, including the RECS in toxin-related injuries, appropriate first aid measures for acute toxin-related injuries, and also appropriate antivenoms for treating envenomation in Malaysia. Like, how cool is that? So, pass it on to Farah.
Okay. In this webinar, we are going to discuss a few clinical cases with our expert panelists. For information, these are the actual clinical cases in Malaysia that were referred to RECS in the past. Without further ado, let's begin our first case discussion. So, I will start with case 1. Next slide. We have 11-year-old Indian boy with no significant past medical history who presented after a suspected jellyfish sting while swimming at the beach. He developed sudden sharp pain over both forearms and posterior thighs, followed by rash, itchiness, and later chest tightness and abdominal discomfort. The father noticed that the appearance of the jellyfish looked like an egg yolk appearance on top of its head. He was initially managed at the GP with antihistamine and analgesic before being referred to hospital. Before we proceed further, I would like to ask to our panelists, based on this history, is there anything important that you feel is still missing or needs to clarify from the HOPI? Maybe we can ask opinion from Dr. Anas.
Yes, I wanted to know, okay, first of all, toxinology, you cannot run away from getting some vitals informations or history, targeted history that we need. So, as for in toxinology history pertaining, you want to know, so you already got the time of incidents, you already got roughly the locations, which is the flamingo. So probably you want to know what were done, I mean, immediately after the patient was allegedly stung by the jellyfish. Any first aid were given, anything were applied to the wound. That is one of the important pertaining to the jellyfish things.
To answer the questions from Dr. Anas, they put the vinegar to the site of stung within 5 minutes after being stung by jellyfish. All right. I think we can move on to next questions. So, in this case, since they put vinegar, is vinegar recommended for jellyfish stings? What are the first aid measures that we can do if this situation occurs? Maybe we can have Dr. Emelia.
Sorry, you were saying?
Okay, so for this case, they put vinegar at the stung of jellyfish. So is it recommended to use vinegar for jellyfish sting? What are the first aid measures that we can do if this situation occurs?
Yeah, a few years back, we were very confident to outrightly say yes. But at this point in time, as we have been discussing, like Dr. Caldun and all my other colleagues, we cannot outrightly say yes at this point in time. But given that circumstance where there are no other modality that you can apply or that you can use, we can use vinegar still. I would still fight for that in terms of experience and its effectivity with the cases that has been observed in cases before. So but like as I mentioned early in my first few words, it is now come to be a more like a controversial thing, and I would I would likely pass the baton to our dear Dr. Kalu to shed
Maybe
light on this, because this is a very important point nowadays. It's like point of discussion, to be honest.
Yeah.
yeah.
Yeah, I think, yeah, Anas, you have an input on
I
this?
just the point about vinegar, I think the misconception is they think is a treatment of the jellyfish. So
Yes.
basically it's one of the first aid, although like Dr. Emelia said, it's controversial and it might be not so useful in certain species related stings. But then we know that it is sort of deactivate the nematosis. But then it's not the concept is not a definitive treatment. That is the thing that the venom will still go in and cause envenoming. Yeah.
Yeah, maybe our friend from Singapore, Lou,
Oh,
would you like,
I,
since you have identified a new box jellyfish in Singapore, how would you comment to your public regarding vinegar use for
sure,
jellyfish sting, especially the
sure.
new one you found in Sentosa Island?
Okay. Hey, thanks for inviting me. I'm Kee Vooi here. So basically, as far as I understand, I'm not an expert, but with my limited experience in the Bangkok Poison Center and also Hong Kong and Singapore as working as a clinical toxicologist, if I'm not mistaken, I do some literature review before when I prepare the slide when I'm teaching the student and the residents. Actually, the vinegar is quite safe in Asia. In Asia, I mean, must put it this word, but in certain species, in especially North America, he will cause more discharges of the nematoxide. There's reason why there's a debate ongoing now. Should we use it or not? So if happen in Singapore, if got vinegar, I will still say safe to use. If don't have vinegar, just use a seawater to stop the discharging. Yeah, this is my own personal opinion. But for sure in North America, try not to use vinegar because you already got a lot of case report causing more discharges, causing more harm. I mean, offhand, I can't remember the species already. I think it's called, I forgot the scientific name already. Sorry about
Physalia,
that.
Physalia, Physalis,
Yeah,
Pisali.
one of them is that.
Yeah.
Got
the
another
blue
one start
bottle.
with C1. I forgot what his name, quite long.
Chrysaora chinensis,
Isaura.
Something like that. I forgot already. It's happened in not America, not in Asian
or
country.
Cynia, maybe. Yes.
Sorry, I can't
Okay.
remember.
Yeah. Maybe Shiro. What is in
Yoshi.
Japan? Yoshi?
Yeah, hi. We have also box jellyfish in Japan,
Yes.
next Yamaguchi, but
Yeah.
I have personally no experience to see such patient. So I also learned this is controversial to do using vinegar for the first aid for jellyfish, but determining the species very difficult in advance. So I have still no answer to this question.
Okay. So the latest update from the guideline is saying that we should just use seawater to rinse the tentacles of the skin. No application of anything else. So vinegar is controversial in the sense it may also cause more pain, but it sort of like stop the new nematocysts from discharge, but it could be that could result in also releasing more venom from nematocysts which has already discharged. So that was the controversy behind the use of vinegar. So at the moment, in our stance in Southeast Asia, we say use seawater. If you have seawater to rinse off tentacles which are still on, of course, try to protect yourself from getting stung from the tentacles while removing the tentacles, and go to the hospital as soon as possible. Okay, so that's the current viewpoint at the moment in time of whatever evidence that we have regarding this subject. Okay, so
Just
back
to
to
add,
our
sorry, just to add, in the presentation of the complaints and the details of the sting, I think you need to also describe the appearance,
yes.
because usually for box jellyfish, we usually observe the whiplash, or the entangled, like a whiplash appearance.
On the
So
skin.
we have to also take note of the appearance of the sting.
Okay. Right, back to our moderators.
Thank you to our panelists and Prof for sharing such insightful thoughts. Now, let's proceed with physical examination findings and see how the case evolved. Next slide. Okay. Upon arrival, he complained of pain and burning sensation over left upper limb and right posterior thigh associated with chest tightness. However, no numbness and no other allergic symptoms. He was not tachypneic and had no signs of respiratory distress or dyspnea. There was no hoarseness of voice. Capillary reflex time was less than 2 seconds, and all peripheries were warm with palpable distal pulse of good volume. Vital sign also stable, and all the respiratory, cardiovascular, abdomen examination also unremarkable. Next slide. All right. There was minimal swelling over the left forearm and right posterior thigh. The swellings were warm and tender on palpation with a pain score of 5 out of 10. Distal pulse were palpable, compartments were soft and sensation was intact. And these were the pictures of the patient's left forearm and right posterior thigh. So, back to the questions. Do these findings point more towards local toxin effect or something that are more concerning? Would any of the panelists like to answer this question?
I'll start off with the discussion of the findings. So, can you go back one slide? I wasn't aware about the BP. Was the BP for jellyfish? You would want to know how is the BP, whether is it appropriate for the center for the age? Looks like it's fair. Okay. So yes, at the beginning when they start to have chest tightness, I think it seems like alarming to you. But after a while, I think it looks like systemically he's fine. It's just that the local part that is okay. Can go back to the move to the next slide. Sorry. So now it looks like more like a local envenomations effect. It's just that does the patient did complain of any pain or any difference in the color of the distal circulation, the distal hands? Any picture of the other sides to compare with?
This one, the pain score is 5 over 10 on the sting side, right?
Okay.
Yeah. So distal pulses is palpable.
Okay.
But I think what you can see, if you can comment, Emelia was saying earlier, the pattern on the skin of the sting. This one is definitely not a box jellyfish feature. It's very diffuse, multiple puncture points, a bit of redness, no obvious swelling, but it's on the forearm and also on the leg near the popliteal area. So other than that, no real like mark like burn marks of a box jellyfish. So this most likely not a box jellyfish. So are we worried or not worried, or what is our concern, right? So yeah. So any other would like to comment about this feature, or have you encountered similar kind of skin marking, Yoshi and Lou?
I mean, not really, because it's not really. I mean, I already know about two lesions, the frosted leather by the box jellyfish. Second is the pearl string
but
light.
it doesn't look like it, right?
Correct. Doesn't look like it.
Yeah.
So
So
yeah, and also from the, I mean, there's no autonomic instability in this patient, meaning no all the symptomimetic the catecholamine search thing which suggests the Irukandji light thing. So yeah, I can't really. I mean, I also not good in identify the other than the all the famous jellyfish. So I will just manage supportive care for now, analgesic and so on.
Agree. But you mentioned about Irukandji syndrome, right? Irukandji. Typically the pain will not be at the bite side. It's not going to be 5. It's much lower. So this one is 5. So there could be some inflammatory cause of this pain on the sting side, right?
Actually, I want to ask, do they do the hot water immersion already or not yet?
No, apparently
No.
not.
Okay.
Yeah. Yoshi,
Yeah,
what do you
for
think
me,
of this? Does it look like
yes.
habukurage?
No, I'm not sure, but the history is stung by jellyfish, but
Yeah.
now this skin finding is kind of diffuse. So I might consider any allergic reaction rather than the envenomation. So I want to clarify. I want to ask any other system. So far, apparently no sign, but I want to consider systemic
Yeah. Will you be
reaction
giving?
from now.
Will you? Yeah. you mentioned about allergic. Will you be giving prophylactic antihistamine or steroids for this? Would you consider that?
If we consider like urticaria, we might use antihistamine if the
Okay.
patient complain any strong itchiness.
Yeah,
So
but
yeah,
this doesn't look like a urticaria rash, right? This is
yeah.
from the
Yes.
sting itself. Okay, so we don't give prophylaxis for this for allergic reaction. Okay, moderators, anything else you want to ask?
So, okay, next slide. Thank you so much. So this is the blood investigation result for this patient. Maybe we can hear some comments from the panelists about this investigation result. Maybe can use Dr.
Anas,
Anas.
this is the initial one, right?
Yeah. I think the initial one probably looks fairly not really significant derangement in any of the you can see the CK probably on the higher side. I think you expect that in a lot of rashes contact with the skin. Other than that, I think it was the urea. Where was the urea? Bottom of UN is, I think, fairly unremarkable for me, Prof.
Yeah, me
Yeah.
too. So because it's initial, so most
Yeah.
likely things
Yeah.
may not
I would
be
want to see serial subsequent blood probably.
Yeah, but what investigation do you think will be more relevant for you? This is a blood test.
Yeah.
What other relevant tests do you think is more relevant that you think for this patient?
I want to know whether was there any skin sampling done, I mean, to the
Yes.
sting site? Was
Yes.
there any? Yeah.
Skin sampling for nematocysts, right?
Yeah,
We
for
look
nematocysts, yeah.
under the microscope.
Yeah.
Yes, that could be helpful. But from the wound, we know that the danger is out of, because it's not a
Unlikely
box
from
jellyfish.
the box jellyfish. Yeah.
Yeah, it's a matter of identifying what other jellyfish could be, and maybe skin sampling could tell us the shape of the nematocysts left on the skin might not be similar to box jellyfish. Okay. So I would also maybe want to consider giving one ECG just to just to have a baseline for this child. ECG. The tachycardia. There was tachycardia. 88, right? There was no tachycardia. Yeah, but just have a baseline.
Yeah, I think because patient also develop did complain of a bit of chest tightness at the beginning. Yeah.
Still early. Yeah. Emily?
Just like to comment, because remember, there are medical students in our webinar right now, and it's prudent to put your range with the results of
Yes.
your investigation so that it would be easier to know. Of course, we have a fairly good idea of like the normal, but
Yes.
remember, we are in different countries. So
Yes.
the machines made or are used are actually different also. So the range can
The
be put
units.
in the investigation, so it's easy and clear that the results are within the normal range.
And the units.
Units, yes.
Yeah. Okay. Right. Anything else? Or can we proceed?
Yep. I think we can proceed.
Okay, thank you. So this is the nematocyst sampling for this patient. And next. And this is the picture of the jellyfish shown by the father. All right, next. For this latter, the child was noted to have reduced radial pulse volume on the left hand. However, peripheral perfusion remained good with capillary refill time less than 2 seconds. Oxygen saturation also good, and heart rate at that time was 100 beats per minute. So, To our panelists, what do you think is happening to this patient? Maybe we can have Dr. Yoshihiro to answer.
No thrombosis was found by ultrasound. Mm, Sorry, I have no differential at this moment.
Yeah.
What
What
happened to him?
was the complaint actually?
Oh,
Was
this,
there discoloration or what?
the child had reduced radial pulse volume over the left hand compared to previous one.
Okay. Is there any color changes to the digits?
So far, no.
No. Okay, just reduce radial pulse volume. Okay. Lou, what do you think? This is already on day 4 of admission.
I mean, how to put it this way? Other than this, do they document any diastolic retrograde flow?
Mm.
Do they document this? Or they didn't do the PW, I mean the power waveform thing?
Yeah, they
If
haven't
patient
done it.
clinical,
They just show a color Doppler of ultrasound, but
I
that's
see.
color flow noted. No thrombus. Color flow means that I think it's flowing well without any backflow.
Yeah.
And it seems to be comparable to the radial artery as well. So,
So
Sorry, may I ask what was the complaint? I mean, from the child. I mean, during this
any
day,
pain,
was it discoloration? Was it pain, or was it coldness of the
coldness? Yeah, exactly.
extremities, or what? Was it mentioned there, or? I mean, there must be something that triggered them to order a Doppler ultrasound, or is just a routine as findings pick up on their CCTVR examination because it's
Oh, yes.
yeah
Because what I can see here, they have also put on
patch.
a kind of a patch, maybe GTN patch. I don't know why, but on the wrist, assuming it's supposed to be helpful for the reduce in pulse volume.
Yes.
So they use GTN patch. Well, what do you think, moderators? Any more insight that you can give us?
Next. Okay, jap. Okay. The GTN patch was initially applied. However, it was removed on the same day because there's no improvement in the arterial pulse volume. Next, on day C of admission, the serial ultrasound showed gradual improvement in arterial caliber from 0.01 cm to 0.04 cm. However, pulse volume still has not improved. Noted that there's a temperature difference at the distal part of the finger, but the saturation still remain good. So, for this current situation, what is your plan of management for this patient?
Interesting. Lou?
Any other
I'm
panel?
just guessing now. Basically, I think
Okay.
what they're doing, they think it's a
Yeah,
contraction, a vasospasm from the whatever
it's quite
effect from whatever.
weird.
Maybe not due to the jellyfish actually. It could be other thing. Maybe some weird syndrome that we never encountered before. Then they try to use a
Yeah,
GTN to vasodilate.
I
Then they
agree.
use the prostaglandin to vasodilate also. So
Yeah.
after the prostaglandin is getting better. So I have, to be honest, I have no idea, but I think the more important is patient stable, clinically getting better for me.
Yeah.
Yeah.
So do you think that the prostaglandin here used is iloprost? I suppose they are thinking of vasodilating the vessel after so-called failure of the GTN. Do you think it is an overkill? Is it too much?
I think it's overkill. I actually
Yeah,
I
I
a
think
bit
it's overkill.
doubt it,
Agree.
because do they really check the both pulse initially or not? This is the first question I'm gonna ask if I was
Yes.
the attending clinician actually.
Yeah, I think they did compare between the left and right, the one that is affected. Here is showing on the affected side that there is improvement of the
Pulse volume.
vasodilate cause arterial to dilate. But the issue is is there actually sign of vascular impairment or vascular what do you call insufficiency to suggest for use of iloprost? To me, what do you think? What are the telltale signs to say this is require chemical drug intervention? So is there really a vascular insufficiency or not?
Objectively, I think, Prof, maybe I think kudos to the team also. They detected quite early.
Okay.
From the difference in the pulses. So
Yes.
probably it would. I mean, the vasospasm. Probably what's happening now is there's a vasospasm induced by the jellyfish things, and maybe
Okay. The
based
venom.
on, objectively are the venom, and based on the serial ultrasound, there are some objective measurements that they come into conclusion that there is some degree of vasospasm, which just not presented. On the physical finding. In terms of cyanosis of the
But there
regime.
is no cyanosis, right? No
Yeah, no
cyanosis.
cyanosis, just the
No,
pulse
that's
volume,
correct.
But
diminished
they
pulse
say there
volume.
is a temperature difference, right? So one side is cooler
Yeah.
on the distal part of the finger,
Yeah.
but no cyanosis, blood still flowing. So is that complete the picture of vascular insufficiency suggest for iloprost? Or is there any other thing that they probably could do to so-called improve the temperature difference? What do you think? So if we go for the typical diagnosis of vascular insufficiency, you must have skin changes, right? The
Yeah.
cyanosis, and then you must have a temperature difference. Okay, you might have pain as well. That's one of the
Yeah.
other worry, right? So these are the three so-called pathognomonic features of vascular insufficiency of distal limbs. So here we are missing pain, we are missing skin changes. And so what we have is just a temperature difference, right? So that kind of not really fully convincing statements points to start iloprost, But however, they appears to be convinced that that causes the vasodilation. So let us see what is the outcome of this after iloprost. How do they give iloprost, and what the other points of the observation can we get from the moderators?
Okay. So iloprost was then initiated on day 6 of emission. While on iloprost infusion, the pulse volume slightly improved and temperature back to normal. Next slide. However, on day 7 of emission, noted that the radial pulse was again not palpable after they will hold the iloprost. Despite this, the limb was remained warm with unchanged temperature and capillary fill time was less than 2 seconds and no associated pain or numbness.
Okay,
And
so
here is the
question
serial
is
Doppler ultrasound for these patients. Any comments from the panelists?
yeah. So Anas, what do you think?
Yeah. I would want to know, how is the regime, being used, the iloprost, because they already started the iloprost, and whether was it stopped immediately once they showed improvement, or was it lowered the dose, or how was it the regime? That could affect, the so-called recurrence of the, potentially the,
Spasm.
spasm.
So do you think at this stage the limb remain warm?
Yeah.
The temperature doesn't change. Capillary refill is less than 2 seconds. No cyanosis visible. No pain is complained. So just they say
The pulse.
no radial pulse, right? So it's based on no radial pulse that they say it's no radial pulse. I'm not sure whether it's really palpable or not, but Was it justification to consider restarting the Ilopros?
Yeah, yeah,
Or
very,
you want to continue observing?
very tricky question for
Yeah, that's why I'm asking.
uh well,
I don't have to answer. You
as
guys
we say,
answer.
sometimes some patient could just be, the strength of radio pulse could be a slightly different right and left. I think
Subjective, right?
probably,
Subjective. But you
yeah,
can use
very
Doppler, right?
subjective assessment, yeah, based on their limbs. But then since they already had objective measurements ultrasonographically, so yeah, overall picture it doesn't point toward uh, a full vasospasm features. But then, yeah, tricky also if they delay. I mean they must be tricky. If they delay, they could develop limb ischemia subsequently because of the diminished pulse. But here I think you can observe or you can start. Probably I would observe first, Papa. I don't know.
Yeah. What do you think, Yoshi? Are you going to be very aggressive?
Of course, I have no clue to restart medicine, but associated no sign of pain, numbness, or the perfusion might be normal might be from bypass perfusion from the urinary artery. So only radial artery might have problem like
Mm, yeah.
transient vasospasm or something like that. So,
Okay.
but
So you would observe first, or you going to do fasciatomy?
No.
of
Because we
course,
had
for
we
now, yeah, I can't start any medicine. Yeah.
okay. What do you think? Boy, Kee Vooi?
I actually will not start it first because I feel like
Yeah.
you're just adding another poison in this. I mean, adding another drug would have complicated the case. There's no
Yeah.
there's no urgent indication to continue all the
Yes.
stuff now.
Agree.
I will
Agree.
I will do watchful waiting. I will see first and see how.
Yes. Yeah. So you need to have a close monitoring of the patient, right? At this stage. So there's no
No hurry to start.
pathognomonification of, let's say, patient having a venous insufficiency except for the radial pulse, again, not palpable. But we can do what do you call Doppler ultrasound to check properly rather than just palpation, right? Okay, so anyway, all agree we could just withhold, could just monitor this patient closely. Okay, next.
All right, so for these patients, the iloprost infusion was given up to maximum dose, which is 2.0 nanogram per kilogram per minute. Then, on the day 10 of admission, noted that the pulse volume started to improve and temperature remains warm with the capillary flow time less than 2 seconds and oxygen still good. Then the iloprost infusion was tapered down to 0.5 nanogram per kg per minute and pulse volume remained stable after being tapered down. Doppler ultrasound post-iloprost also show improvement in the distal artery and ulnar artery size. The pulse was also easy to feel and palpable, and then the child was discharged. Before we discharge the children, I want to ask to our panelists, what is your advice that you want to give to the parents?
Yeah. Emily? Emelia?
Unmute. I think she hasn't unmute.
Is she around still?
Unmute. Okay.
Okay.
So as we have agreed earlier, I think it would just be good to have like watchful waiting also. And just observe if there will be like any changes like pain, discoloration again, or any other possible issues later on. Because this is day 10 already, and like,
Yeah.
so we all know that if there's really a systemic issue and a major issue, then the patient will not present in this way. So
Yeah.
it's like we just need to make sure or reassure the parents also. So one step ahead in terms of just telling them that, you know, if they observe something different or something like that, or that needs urgent um check, then that's the way to go. Because as we have agreed, all of us, like it's like some sort of an overkill, to be honest. So yeah, and uh this modality is not available in many centers. So
Okay. All right. So, Anas, you want to
Yep.
comment? Are you okay? I mean, it just shows that they proceed anyway,
Yeah.
with
Yeah.
the Ilopros regime and appears to be uh responding well.
Yeah.
So the question is, what do you do then after you discharge this patient? Is there any advice you give?
Yeah, for me, I'm worried of recurrence or revasospasm, especially after you off the infusions and also the medications prior to discharge. So need because you need to you need to advise the parents that this thing might recur. I think yeah, that's the most important thing, Prof. Recurrence, and
Okay,
you
so
could have given a follow-up probably to your clinic, early
yeah.
follow-up and review the hands.
Yeah, so just to recap to medical students that this can happen in jellyfish sting of, in this case is unidentified jellyfish sting and definitely not a box jellyfish, but vasospasm can occur and it can present as a delayed vascular insufficiency.
Oh.
Yes, we agree that Ilopros seems to be working to reverse the vasoconstriction, but we're not using it like for everybody. You have to have proper indications to give Ilopros. In this case, we haven't really fully established that it is a vascular insufficiency. It might just be partial, but not really causing impending danger in terms of hypoxia to the distal limb. So yeah. Anyway, just to let you know, background, that Ilopros is used for a condition called Raynaud syndrome. If you are in a cold place, then suddenly you feel your hands turn blue because of the cold. That could be a Raynaud syndrome. Well, first of all, you just need to warm up your hands. No mention here that the patient was given a warm blanket to the hands to so-called like help if there is, because the patient felt cold, right? They feel cold. So maybe a warm blanket could help in the first place rather than straight away giving Ilopros. But they did do ultrasound, and I commend them for their effort. And it shows improvement after giving the Ilopros. So at least there is showing effectiveness of Ilopros, whether it is indicated or not indicated. It just shows there's vasodilatation response to the Ilopros. Okay, so
Yeah, another one, Prof. The GTN patch is in this case is of no use. I mean, there is no indication or usefulness
no,
whatsoever for the GTN patch for this type of case.
no,
Yeah.
I don't know whether why they need to put the GTN patch in the wrist anyway, because the GTN is absorbed anyway from any parts and goes systemically, right?
yeah.
So why is it on the wrist? Okay, yeah. Anyway, yeah. Yoshi and Kee Vooi, any last words for this case? What do you think?
If I can ask, do you have any publication about this type of findings after jellyfish?
Yes, I will share it in the comment.
Yeah, that's very impressive. I appreciate this case.
Okay.
I think it might be overlooked because I think the trigger of the Doppler ultrasound was the
Yes.
only physical sign, and
Yes.
the patient didn't complain any pain. So
Yes.
I think if me, I might overlook, just misunderstand. Yeah. So I just appreciate this case.
Yeah.
Yeah.
Okay, thank you.
Thank you.
We learned something. Okay. Kee Vooi?
Oh, no other comment. I also learned
Okay.
something new today.
All right. Okay. So I'll share the link of the case reports in the comment. Moderator can move on to the next case, or you have to comment for this case, or any
Thank you to
questions
our
on the
panelists
floor?
and also Prof.
Any
So
question
now
on the
let's move
floor?
on to the case number 2.
Any questions from the floor?
Did the patient follow up? Was the patient seen for follow up?
I think they did follow up, but it's just that we did not get the latest info or updates from the team
Okay.
lah.
Yeah, because this case is a Rex consult case.
Okay.
Is there any questions from the floor before we proceed to case number 2?
It's okay, can continue, and if there is, we will.
If no, then we can proceed with case number 2.
Okay, so dear panelists, let's start with case number 2. Right, so this is a case of a 2-year-old Malay male. The location of incident was in the house. So, patient was about to fall asleep on the bed. So, how did the patient got bitten by a scorpion is that the child was getting ready to sleep on the floor on the master bedroom together with the father and also the mother. So, they had just finished tidy up the room and the room was partially darkened. The father suddenly saw a scorpion near the child and immediately reached a pillow to hit it. Next slide, please. So while doing so, the scorpion crawled up towards the child, but rest assured the child was wearing socks. Child suddenly cried and started to scratch his right foot. So the mother went to open the room lights and noted a scorpion under the pillow. The stinger, and the father noted that there was a stinger. So the stinger removed by father and brought the child to the emergency department. So before proceeding further, so dear panelists, based on this history alone, is there anything important that you feel is missing or you want or need clarification from the HOPI? What are the things that you would like to ask the father? The floor is yours.
Okay. The things is okay. So, they assume that the child was stung by the scorpion, right? They did not see it, but however, there was so-called stinger. So you would love to see that picture of the stinger, if any. But I want to know what was done or what were done pre-arrival to hospitals, because our society loves traditional first aid for bites and sting. They love tying. They love a lot of many first aid, traditional first aid. So anything was done to the child?
Before bringing Bond to the emergency department, there was nothing done. The father immediately brought to the emergency department hence.
Okay, so the child was sleeping on the bed, I presume,
Floor.
or in the
On the floor.
on the floor. On the floor. Okay, all right.
Then
Sleeping on
the scorpion was found by mother under the pillow. Is it?
Yes.
Quite interesting. How did it get under the pillow?
The father said that he struck it, right?
Okay.
It says the scorpion crawled towards the child. Child was wearing socks. What does it mean? Anyway, it would be nice to see the affected side, right? And if the father already killed the scorpion, any picture of the scorpion, right? So those are the things that we ask when patient arrive to hospital. Kee Vooi, anything to ask Any points at this stage? Missing info?
I mean, I want to ask that the father really see the scorpion sting the child
Mm.
or not is more
Yeah.
important because you don't assume whatever patient say is true. Sometimes
Mm.
it's another thing sting or actually there's no sting, but the stinger
Mm.
removed by the father. Today,
Mm.
for sure, I mean, later they will show us the wound and what kind of
Mm.
stinger and so on. I want to know about that.
Stinger, yeah. Because the
And
mother
I'm
went to
also
open the room
thinking,
light. Mother went to open the room light. Was it dark at the time when the child got sort of like
yes,
sting, right?
they
It's,
started to darken the room.
the story doesn't really, follow
And
well.
the stinger, scorpion.
Yeah. So stinger doesn't stay behind, right, from scorpion.
No, but
Yeah.
bee.
B, yes, that's right. Yeah. So this is all kind of make things more headache for junior doctors, huh? How can all these things happening?
Yeah.
So it's not clear. So maybe we have to ask, just show us the site that is bitten or stung, and also if there's any picture of the animal that they kill. Okay. Was the scorpion killed?
Bite marks.
Huh?
Yeah, there was a picture of the scorpion. Can we go to the next slide,
Oh,
please?
yeah. Okay.
Oh, and also, part of the body that was affected was the right foot. So what was done to the affected region was the parents just removed the socks and noted there was skin redness post scratching. All right.
So was there a scorpion? Yeah. Okay. Right.
So they use nail clipper
Okay.
as a
So
size.
this is maybe
Size of the nail cutter.
Yoshiro's expertise, maybe. What do you think of this scorpion?
No, this is not my expertise,
Oh,
unfortunately.
okay.
But actually, even in Japan, we have no scorpion,
Oh.
even non-venomous. Very remote area like
Mm,
Okinawa has only some scorpion.
mhm.
But of course, I want to learn from this. I just
Okay.
curious if the patient had a severe pain because I
Mm.
know scorpion bite usually cause severe
Sting.
pain. Yeah, sting, sorry. Yeah.
Yeah, so I think I can tie up back to the history. Maybe what it want to say is the child was wearing a socks and the scorpion was in the socks, and it stung the child, and that's why they removed the socks. I think that kind of a bit more, coherent type of history, if that's the case. Yeah. So
Another
apparently, if you look back at this, can you see the scorpion? What do you think of the size of the scorpion?
It's so small.
Emelia?
What is
Yeah,
that nail clipper? Is it the big one or the
yeah.
small one?
That's another issue, right? There are
You
yeah,
know,
many sizes of nail clippers.
yeah.
So, but this one is it's a small nail clipper, I think. So it's rather
and
small
scorpion.
scorpion.
Yeah, baby scorpion.
So
I want
yeah,
to
if
ask
you
also, Prof.
uh
Was it this is the picture, the left and the right picture are the same scorpions?
yes,
Okay, because I think for students, sometimes we need to
mm,
be careful as well because
yes,
sometimes they just search a picture from Google and then show
yeah,
this is the similar looking species,
yes.
so we can't really assume. So yeah, but because at the sting, the side there, okay, this is something on the top of it lah. Okay,
So on the
right.
foot. Kee Vooi, you have this in Singapore?
I'm not, to be honest, I'm not really sure, but I
Yeah,
believe,
I can tell
Malaysia,
you, you do have, okay.
but I believe Singapore or Malaysia scorpion is, I mean, so far I never came across the
Okay.
venomous scorpion that can cause mortality or morbidity in the Singapore or
No.
Malaysia so far.
Yeah.
There is it?
But
This
this
is
is one of the smallest, one of the small, what we call bark scorpion,
Lycus, is it?
bark. Yeah, Buthidae species, Buthidae genus, and oh, sorry, Lycus
Lycus.
genus, and it's small, and it is actually can be easily imported via fruits that we import. So, for example, because this is small, so they hide in between fruit bunches. For example, the the langsat duku, yeah, so they come in a bunch, so it's hiding inside that. So when they sort of like bypass the cleaning station, sometimes they are still alive, and they reach our supermarket. And when people buy, selecting the fruits from with their hands, they got stung. So we had a few cases like that. Or when they're eating the fruit in the car, suddenly got stung as well. So we had cases of those. And all is small, but the stinger is can be very painful. So the sting can be very painful. The issue is rather small, so it might have difficulty to pierce your hand, your callous hand skin. So, but then if other parts is thinner skin, it can be quite significant, I think. So far, nobody died. Nobody had any allergic reaction to this stinger. I had one, and I put it into preserve it, brought by patient, so live one. So I preserved it. It's in UKM museum, so it's nice. So we can identify it straight away. This is one of the Lycus species that we have. It's small. The other one that we have is the black one, the giant, what you call the forest scorpion. That is a very big. People keep it for pets or as pets. Okay. Yeah. So next, what else? So question is how do we manage this case, right? We've identified scorpion. Okay, verified scorpion. So moderator, what's next?
Okay. And also for this case, is it important to identify of any neurological symptoms? And why is it important?
Do you think it's going to be a neurological symptom? So, Anas, Scorpion's team. Dr. Anas is our arthropod expert.
No, not there yet, Prof. But yeah, good questions. Basically, our Malaysian species are mostly they are venomous, but we don't have any. So far as that I know, we don't have any systemic envenomation following scorpion stings. Mostly are self-limiting and can be treated symptomatically. But yes, neuro. When you ask about neuro, of course, for all other patients, we monitor the neuro, but not for the scorpion sting. I mean, for our local species of scorpions. Unless they got bitten and suddenly develop another sequelae of concurrent illness. Yeah.
Yeah, so close monitoring is important, and nothing really specific for investigations. You can treat, I think, symptomatically, conservatively if you want. But we do have incident of patient keeping what do you call venomous scorpion from Middle East. So those are what you call it, the death stalker. Those are quite significant, and they have antivenom for those. So patient can, if I'm not mistaken, it has a neurological neurotoxin, if I'm not mistaken. So that's why they have antivenom for that scorpion. But it's in the Middle East, not in Malaysia. But people keep it as a pet. That's the thing, and they got stung when trying to hold it. Or yeah, we had a case. So it's not yeah, people are crazy, I think.
A
So
pet.
all kinds of things. Yeah.
How do they take care of it, Doc?
Yeah, just give what do you call they eat I kept one myself, but not the yeah, I kept the Malaysian one. We can just easily feed them with what do you call cengkerik. What's cengkerik? Crickets.
Okay.
Yeah, they eat
Oh,
cricket. Yeah.
where do you get these crickets?
From the pet store.
Oh, really?
Yes. Many
That's
other
interesting.
pets eat crickets as well. So, or
Okay,
fish, right? Fish. Some people feed fish with live crickets. Yeah.
that's
Yeah.
interesting.
Yes. Okay. So, for Okinawa, as Yoshiro mentioned just now, sometimes you import fruits from tropical countries like Southeast Asia. So just be careful when you are selecting these fruits from the market. It might be hiding inside the bunch of fruits.
Wow.
So
Okay.
yeah, just be careful. We had a few cases, and these are the fruits imported from Thailand
Yeah.
in our supermarket. Yeah. Okay. So obviously, if Malaysia has, Singapore probably will also have it, but maybe they use some kind of pesticide before putting it on the supermarket shelf, so it's rather safe. Yeah. Okay.
All right, so for the patient, upon arrival at ED, the right foot noted that there was no obvious stinger marks, no redness, and also no swelling. And the patient noted that the pain score was just 0. So there was no associated with vomiting, dizziness, dyspnea, palpitation, or any GI losses. So he was given syrup paracetamol instead. So upon general condition, he was not in tachypnic, no respiratory distress, and no dyspnea, no hoarseness of the breath, hoarseness. So the CRT was less than 2 seconds. All peripheries and distal pulses were warm, palpable with good volume. So vital signs showed that the patient is hemodynamically stable with a respiratory rate of 20 breaths per minute, and the saturated oxygen was 99%, and patient was afebrile. So we did a systemic examination, noted that the lungs was clear, equal air entry bilaterally, CVS was dual rhythm, no murmur, and the abdomen is soft, non-tender with no masses. All right, so this is the local examination of the right foot. As you can see, there's no obvious stinger marks, no redness, no swelling, and the pain score was still 0. So, panelists of the floor, what would you like to discuss
So
on arrival of the
And
ED?
I have a comment again. Pain scale. What will you count if there's 0? So just put no pain. I don't think it is acceptable to say 0/10. Agree? Disagree? I don't know. But as I'm concerned, just put no pain. Because when
but
we say scale, there has to be a value, right? 1 to 10. We don't say what is how if you will rate your pain from 1 to 10, you don't say 0 to 10,
I
right?
I think
Agree.
if I can say, so this boy is 2 year old, right? So it might be very difficult to scale the pain.
yeah,
So
yeah.
it might be mild pain or I don't know, really no pain. But just a
But
comment.
but but Yoshi, I'm speaking in technical terms. I mean, like
Okay, okay, sorry.
that we are talking to medical students. So, I mean, in the future, I don't think that's acceptable to say 0/10 because it's a scale.
Yeah, for the picture of so there wasn't any swelling at all. And usually, do you have any picture to compare the other foods? No, or these are the only pictures available.
This is the only picture.
Okay, so the back to the initial one that father removed the stinger. What did he mean by that at the beginning? Was it any
Probably
stinger stuck on the foot or something?
That's strange. No bite marks. If
No.
your father removed the stinger, there should be a bite mark at
I
least.
not bite marks. I mean, it
Oh,
doesn't bite, it stings. Yeah, but
yeah,
the thing is that is the stinger. So I most likely probably remove the
The scorpion.
scorpion rather than yeah,
Okay.
because it's small.
yeah.
Okay,
Okay.
all right. So conservative management can discharge home.
Yes.
Yeah. So
Leave
nothing.
it late. go to sleep.
So upon investigation, we did a FBC and also runner profile. So panelists of the floor, what would you like to comment about the investigation?
Nothing extraordinary, right?
Yeah.
Yeah. Okay, next.
So the plan for this patient is only to continue observation under room air, watch out for any systemic or local envenomation, and therefore discharge the patient.
Okay, agree.
Yeah.
Okay, thank you. Next case. Do we have another case?
Alright, so now we move on to our case number 3, and this is quite interesting. And this case is a new case reported earlier this year, if I'm not mistaken, January this year. Next case. A 10-year-old boy was brought to the hospital after being stung by a ketuka fish, a small species of stingray, while swimming at Tanjung Asam Beach, Gerak, Sanggol, Penang. He developed sudden severe pain and bleeding from the right foot after reportedly stepping on a sharp object in the sea. Initially, they thought to be a rock. The pain was severe and he was unable to bear weight or tolerate touch to the affected limb. He was initially brought to a nearby clinic for a wound cleaning. However, due to persistent severe pain, he was subsequently referred to hospital for further management. The patient continued to experience significant pain during transfer and required ongoing observation and treatment upon admission. And it also reported that the venom from the fish may still be retained in the foot with a suspected fish spine embedded in the wound. The child remained under treatment at the hospital with ongoing fever and incomplete resolutions of toxin effects. So, the first question is, based on this presentation, what are your immediate concerns for this patient following a stingray injury?
Interesting. Well, this is a news report, right? Okay, so maybe our panelists, what is your concern? Stingray, Kee Vooi, you
I-
have it also?
Yeah,
Uh,
I mean, I will for sure I will clarify history again. What you were wearing? Is it barefoot or wearing some?
yeah.
Most
So
likely it's
say,
a barefoot, I guess.
yeah. Most likely it's a barefoot. But the question is, what is our concern here if for this type of injury? Are we concerned about envenoming or are we concerned about something else?
I'm just clarify. Is it they're really sure it's a stingray, not other spiny fish, right? Because from
Yeah.
the history, it's like the ketukat fish is the stingray, lah, huh?
Yeah.
Hmm.
And I'm
Only.
also like
So
fish and then stingray
Yeah,
or
the question is we don't have a picture of the so-called fish, the ketuka fish, right? They did not provide. So how did they come up with that diagnosis of ketuka fish or stingray? So we don't know. And there are many other stinging fish in the sea, right? So what do you think?
For me, Prof, it could be two things. Immediate effect is either based due to the local envenoming effects. Secondly, it's because of the mechanical, because we are talking about stingray, so sometimes the barb itself can puncture, cause significant tissue injury, and could be retained foreign body that causing persistent pain. And
Yes.
if the foreign body is large enough, it also cause significant wound that could be contributing to the pain as well.
Yes.
So two things for me, envenoming and also the mechanical injury resulted. Yeah.
So, Yoshiro, are you okay with the diagnosis? Saying it's a stingray
Yeah, I'm
from
just
this news.
curious the size of stingray. Does mention the small species, but sometimes stingray the variable size and
Yeah,
depending
so
on
there are
the
many
size.
sizes. So
Yeah,
ketuka is a small stingray. We eat it by grilling. It's very nice. Okay, so anyway,
I just want to add
yeah,
something, Prof.
yeah,
For benefit,
yeah.
for benefit of medical student, when
Yeah,
whatever history you got from the patient, family member, you need to
verify.
you need to analyze it whether it's true or not. Number
Yes,
one.
Yeah,
That,
Number two,
exactly.
I mean, I'm emergency physician. So the first thing is the worst case scenario. In the
Yeah.
sea, the worst one is sea snake, but from history, it's really step on something sharp.
Mm,
Can maybe something glass foreign body is not really the animal.
exactly.
Number two is
Mm,
a spiny fish like Dr. Anas say, stonefish or
mm,
waiver fish, other type of spiny fish lah. If a
yeah.
stingray is really only got the traumatic and mechanical injury instead of the envenomation lah. So take the patient history as a pinch of salt lah. Next time when you graduate as a doctor, yeah, correct.
yeah,
This is a comment.
Yeah. Okay. But stingray do have venomous barb.
Yeah.
Okay.
Yeah.
But it's not from a gland. Okay. So it's a barb. Yeah. Yes, Emelia.
we can also think of a sea urchin.
Oh, well, sea urchin, yes, but you will be seeing the sea urchin. You can see the sea urchin. It's black, and the spine will be retained, definitely.
I also was thinking initially, so he was already swimming, so he was in the water, right? Yeah. So
Mm,
he will not be able to really see what
mm,
stepped on. So he just
yeah.
said something sharp. So yeah.
It's a sharp object in the sea. So that's what Kee Vooi was saying. It could be anything, right? It could be a
Broken
glass
bottle.
or something, yeah, even a coral. So it could be
Yeah.
anything. So that's why I was saying just now, why they jumped into conclusion saying it's from ikan ketuka or ketuka fish or
Yeah.
stingray. What is the
Mhm.
evidence? So that isn't. So this is another thing that I think our media needs to learn to not just simply put the for the sake of the title for the news, unfounded diagnosis like this, right? So it give a wrong impression sometimes.
Yeah.
So my first thing, as I said, was probably maybe nothing. Could be a stonefish, as you know, which can cause severe pain and quite a persistent pain as well. Uh, as Dr. Anas was saying earlier, if it was a ketuka, then the spine of a fish might need to be excluded. So X-ray of the site of sting will help us identify if there's any foreign body left. And of course, the third one is the issue of secondary infection, right?
Yeah.
So could be marine infection. So if there is a wound or skin break, then you may want to consider either prophylaxis or on top of that culture. But the problem with culture marine is it's a marine organism. So the culture that you use should be in the environment of a marine as well. So you might need to use a saline type of culture to grow. Otherwise, it will not grow and it give a false negative findings. Okay, right. Yeah. Any other input you want to give about this case?
Yeah,
So
another thing about
the main thing is do not jump into conclusion lah. What cause? So you have to be thinking wider. So it could be a false flag, you know? Yeah. Okay. Anas, what do you say?
I was asking, I will try to ask whether is there any picture of the
Wound.
so things like wound or the
Yeah,
food.
because this is from the newspaper.
Okay.
So I thought it was interesting,
Another
to learn.
commonly asked question, Prof. Any role of hot water immersions for stingray?
Yes and no. To me, I would rather just give our analgesia rather than wasting time and using the hot water if you are already in the hospital.
True.
So
Another
for
thing
this
is the
case,
practicality of hot water immersions
yeah,
in ED.
yeah. Some people are a bit hung up on hot water. Yeah. Okay. And so, can we have another case? Or do we have any question from the floor? Students or participants, any questions, please type in the chat. Okay, next case.
All right, so we can go to case number 4. Next slide, please. All right, so we have a 27-year-old Singaporean preschool teacher died from a suspected snake bite on her toe in Hainan, China on the 2nd of June. So the victim experienced nausea, vomiting, numbness in the right lower limb, also slipping in and out of consciousness and therefore falling into a coma. So what happened was, when the patient got a snake bite on her toe, she was with her boyfriend at that time, so they just rinsed it with normal water and then suspected that she experienced all this nausea, vomiting, and numbness. So they rushed to the first hospital. And when she rushed to the first hospital, they only did a simple management, such as taking blood tests and even intravenous drip. So it took her 3 hours in the first hospital. Then the doctor came to her and said that we don't know how to treat this snake bite, this allegedly snake bite. So they said that you have to go to a second hospital. So she was carried into an ambulance to take to another hospital, which was more than 4 hours after she was allegedly bitten. Upon arrival to the second hospital, they didn't admit her into an ICU because they think that this is not a severe case. So she received treatment at the second hospital, just a conservative, like intravenous drip, and she was pronounced dead at around 7:20 a.m. So, upon this newspaper, what do you think is the contributing factors to this tragic outcome? And how can we fix this in the future? The floor is yours.
I think it's very interesting news. Anas, now you have the picture of the bite site there in the newspaper.
Yeah.
And she's a
Oh,
Singaporean. Huh?
okay.
But then the incident location is in Hainan, China.
Oh. So, okay. So actually,
So do you agree with this? What do you think of this case? Is it a snake bite? If so, what kind of snake do you think causes this? Is
okay.
it venomous or non-venomous?
So actually, the picture of the toe is not really clear. But was there
Yeah.
any dermal necrosis there, or
Doesn't look like it, huh?
you like it? Yeah, agree. Well, it's many questions. I mean, was wondering in my head lah. A lot to be asked. Regarding the incident, etc. The location. She was in the. I presume she was holidaying in China.
Most likely.
Most likely. Where was it? Was it in the sea or somewhere, or
On
not?
land, right?
Forest,
Land snake.
the forest on land.
Yeah,
Oh,
okay, you need to know the
okay.
location. Okay.
So definitely at the beginning, after bitten, she developed some early systemic envenomations, as evidenced by nausea, vomiting, and this
You're
is
talking about neurotoxicity?
most likely it's a neurotoxicity snake species that were involved, and yeah, because the duration after she collapsed is quite fast, so most likely it's some neurotoxic species.
Yeah, I think it's a kind of neurotoxic
Yeah.
species, but as you said, it's Hainan, China, so we probably need to know the
Yeah.
local species in Hainan, right? What are the local venomous species, and then try to work from there. What do you think? Kee Vooi, you're in Hong Kong?
Yeah, I mean, if I'm using the Hong Kong common neurotoxic snake to manage this case, if usually it's a many banded crab. I mean, we
Yeah.
only have a banded crab. We do have many banded crab. And the Chinese cobra, the Naja ultra, if I'm not mistaken, and the king cobra. These three will cause neurotoxic in Hong Kong, but I'm not sure about Hainan. I just extrapolate my knowledge from Hong Kong to Hainan, China. Then
Unlikely it's going to be king cobra. As you can see, the bite site there is rather inconspicuous.
Yeah, by the way, don't trust the mothership, the blog there. Sometimes they also got a lot of false information, just in case everyone don't.
I
So,
mean, it's just a nice discussion, hypothetically, right? Yeah.
correct. So this the three snake I will worry about lah. But I mean, for sure we don't have any information. I don't know why the China doctor will turn her around when when already got all the neurotoxic
Yeah.
symptoms like coma, sleep in or and off consciousness. I mean, it doesn't make. I mean, for me, I can't connect all the dot lah. If this kind of
Yeah.
patient come to any hospital, if I don't want to give antivenom, I will admit for observation at least lah.
Yeah, at least that's the way we're thinking of. If you don't have any antivenom, even your ABC should be monitored, and you intervene as per ABC lah, right?
Yeah.
You don't need to have antivenom not to what do you call observe or monitor the patient or support with whatever you have. So if patient collapse, then if the airway is the issue, which I think could be the issue here, then you
Resusc.
intervene with airway,
Yeah.
intubation, ventilation, right, to support.
Yeah.
So you can still do that. So that's the thing about neurotoxic envenoming. People think that it will kill you straight to the heart, but it's actually is the airway is the issue. Patient not able to breathe, the paralysis. So if you take over the breathing effort, patient should be okay. So yeah, but that's the question where we are not saying that they are not doing anything, but this is what is reported, right, in the news. So just to bear in mind, if we face something similar like this, antivenom should not be the first in our mind. The first, as emergency physician, emergency doctors, is to manage the airway breathing circulation first, stabilize the patient. Antivenom can be given if they are indicated later. Yeah. So ABC comes into play first. Yeah. So as you said correctly, we need to know what is the local species. So if there is not much pain and there's no demonecrosis, as Dr. Anas was suggesting, I think Yoshiro did study in Philippines. There's not many also bite from cobra causing demonecrosis, right? Betul? Is it correct, Yoshiro? The Eastern
Actually,
Visayas, or do you have a lot of necrosis?
yeah, in some Visayas we have Samar cobra, particular cobra. Compared to the Philippine cobra, we observe sometimes a necrosis. So as far our observation, relatively higher percentage of complications of dermatonecrosis.
So you see more neurotoxicity rather than demonecrosis, correct?
Yes, of course.
Yeah.
Some are predominantly cause neurotoxic, but
So
complicated
it's a kind of a slightly
necrosis.
different to Naja Atra in Taiwan. They see more skin necrosis compared to neurotoxicity. So for us here in Malaysia, we are mainly seeing more neurotoxicity compared, but we also have quite bad skin necrosis. So yeah, so depending on the species of the cobra. So, but I think most of the bite from cobra will cause severe pain, right, Lou? Okay, boy.
Yes. Yeah.
Even from
Yes. Yes.
cobra
Correct.
will cause a pain, severe pain, and swelling. So if this picture is to be
Right.
trusted, that it surely doesn't look like much swelling and not much demonecrosis there. So most likely candidate will be probably with a small bite mark there, probably a crate possibility, right? So I'm just
Just for yeah. Just for
hypothetical.
benefit of a student, usually the
Yeah.
king cobra will hold on when biting the patient. So you like something
Yeah.
like chewing kind of sensation. If the other naja just very strike, just bite like this. Yeah.
Bite and let
Another
go, right?
second, yeah, correct. Very strike. I mean, just strike and let go. Second thing is
Yeah.
when dealing with neurotoxic snake, a patient might mimic the brain death. So I mean, when you graduate as a doctor, when you deal with all this kind of neurotoxic snake, just I mean, in Malaysia for sure you got a Rex to call but in the other country you might need to think twice before you pronounce death the brain death especially.
And I'm just wondering the travel time, which is 4 hours, like in China, like how remote is this? Like
Yeah.
like if you're traveling like 4 hours, I don't think you will not be able to have a big hospital, or shall we say a tertiary hospital along the
Yeah.
way. So there are so many gaps that you can point out or that you can see in the news beat that we have here. And
Yeah.
also, like for example, as what Dr. Ka was stressing on, is the ALS. We need to do the basic thing that we have to do when we are presented with these kinds of patients. I mean, there's no, I mean, time is very essential in these neurotoxicities from these kinds of snakes. So we should not waste time and really do it right. Something like that.
Yeah.
Do
Yeah.
it.
Okay.
Because Hainan, Prof, if I'm not mistaken, Hainan is one of the they are famous for the beaches, right? Island. So that's why I was thinking at the beginning,
Yeah.
maybe Britain, I mean, just go on the sea tour or something. Then
Yeah, but then you have to be at the sea lah.
yeah,
Sea.
but the duration 4 hours.
Very unusual for sea snake to bite tourists. Most of the sea snake bites are involving
Yeah,
people handling
fishermen.
snake,
Yeah.
handling the snake.
Mm.
So the ones that got bitten by sea snake mainly what you call fishermen
Fishermen.
rather than tourists walking by the beach.
Bad like as was Anas was saying, if it's a tourist area, so for sure there is like a private hospital or
We
equip
don't know.
that should be around, and this is like
Yeah.
China. They were able to build a COVID hospital in 10 days. I don't
Well,
know how you
we
can.
don't know. We don't know how is the situation in Hainan, but
Yeah.
whatever it is, if this story is true, as Kee Vooi was saying, it's from mothership, it could be anything, sensationalized story. But if it was true, then I think there could be a lag in the medical treatment. I would say earlier on, why they're waiting so long, and then no mention of antivenom as well. So if they are thinking about envenoming, I'm sure they do have antivenom for the local species in China. Is it true, Kee Vooi? In Hong
Yeah,
Kong, you have, right?
Hong Kong is very special. They store
Oh,
anti-venom from Thailand and China and
okay.
Taiwan.
Yeah,
Wow.
because
But
you have
I'm
the
I'm not sure about
for that.
China. I'm not sure about China.
Yeah. So China also has king cobra as well, so I'm not sure whether they
Oh
have
God,
the antivenom for that.
I mean, from the China colleague, when we meet in the Hong Kong, they say they have own local anti-venom.
Yeah, okay. So we assume that they have. Yeah. Okay.
Prof, I think this case also highlight another issue. I mean, like
Mm.
first we receive consultation, like we are trying to move unstable patient from one hospital to one hospital just to
Yes, yes.
get
Exactly. Yeah.
antivenom. But then with our, I think with assistance, sometimes we advise to move antivenom instead of moving the intubated patient to go to another hospital or
Yeah.
ICU.
Yeah.
So I
Yeah.
Mm.
think this is another thing that we can consider. I mean, instead of mobilizing the patient, so because could be the reason they want to transfer her because they don't have antivenom there, or maybe some financial reason or something. We don't.
Yeah.
Yeah.
That
Yeah.
can also be a reason. I agree, Anas.
Yeah.
And
Yeah.
this is like a very good example of fast critical thinking in cases like this, because you already have all the urge, signs of urgencies. Like I mean, you have to really act on the presenting signs and symptoms of the patient. So airway, of course, ABCs. Go back to those basics, ABCs.
Mm-hmm. Yeah. Okay. So, do we have time for another case? Any questions on the floor?
We have one more long case, Prof. Would you like to proceed with the case 5?
Do we have time? Maybe a quick one.
All right, so we will start with the last case. So Mr. M, 70 years old male with no known medical illness. So he presented with an allergic snake bite today at 1 p.m. So patient was hunting alone in the forest, subsequently stepped on a snake, and the snake bitten the patient once over the left lateral leg. Patient did not notice the snake prior to stepping on it. So the snake left the scene and the patient ran away post-bite. So patient noted that the pain score was 6. Subsequently, patient tied a cloth to his left leg. Post-trauma, still able to ambulate to seek for help. So he went to his friend and his friend drove him back to his longhouse. So at the longhouse, the family member pricked the wound using a knife to release the blood. All right. At 1:30 p.m., 30 minutes afterwards, he started to have drowsiness, subsequently sent to the hospital. All right. So next slide, please. So he described the snake as black in color, yellowish stripe over the front, 50 cm long and 15 cm circumference. So he mentioned that the snake as ula belalang, but unable to identify the snake from the CPJ. So from this presenting complaint, this HOPI, what are the other things that you would like to ask this patient? Again, floor is yours.
Who gave the diagnosis of Drimacron cooperi? The doctor?
The doctor attending was the one who...
The doctor consulting Rex saying that this could be okay. So the doctor made the diagnosis. Okay. So, okay. Panelists, what would you like to ask?
For sure, need to know where is a geographical location whereby the patient was bitten first. Is it
Yeah. So,
Peninsular Malaysia, Sabah, Sarawak?
moderator?
Do you have any information about that? Because at Longhouse, I assume it's Sarawak or Sabah.
Sarawak or Sabah. Yeah, Sarawak lah mainly.
Sarawak.
Then, if I'm not mistaken, in Sarawak, some of the Malayan pit viper is not there. At least you can slowly rule out the species by species. Then for sure, you need to know that the snake fall down from the tree or on the ground. This is a certain thing you need to ask the patient with long. And also, what kind of mechanism or injury?
How
Even
did
though you
he
say
get bitten?
step back on this and what he's doing, wearing boot or not. And I think from the history, we already know he do a lot of voodoo medicine, right? He tied a cloth, he even cut it, and so on.
Voodoo. I like that. Voodoo medicine.
Do they put a black stone? I'm not sure. So this is the thing we need to know for the snake bite. Yeah, and if possible, I don't know whether the patient will. Patient got capture the video or the picture of the snake. And for sure the doctor will take a bite wound, the bite wound the so-called the wound, puncture wound or what to see is it tally with the history or not and whatnot. This is a history I'm going to ask.
Yeah, okay. All right. I agree. Yeah. So can we move on to the next slide? So we think that this diagnosis is maybe incorrect because it's not a Malaysian snake, right?
Yep.
It's not from Sarawak, so could be something else. So let's see. Can you proceed, right, Rina?
All right, so the general condition for the patient's alert, conscious, and the GCS was E1, V2, M5. Pupils was reactive, and patient was not insubcapnic, good pulse volume with a warm peripheries with a CRT less than 2 seconds. BP was 135/90, the heart rate was 82, respiratory was 18, and temperature was afebrile, with a saturated oxygen of 100% under high flow mask. So looking at the left leg, there was a multiple bite wound noted over the lateral aspect of the left leg. No active bleeding, and it was tender, and range of movement was all jam for is full, and the pulses was palpable. CRT less than 2 seconds, and there was no dermal necrosis or any enlargement of lymph nodes. So upon systemic examination, the lungs, CVS, abdomen was all normal. So I'm going to show you a picture of it. So
Mm.
this is the left lateral aspect of the legs.
That's kind of
And
Okay,
do take note that
Emily, what do you think?
that's kind of weird.
I think that's the intervention that he did, right?
Yeah, the pricking and the
Mm.
cutting. I think that's why. And then we cannot identify where the bite marks is already. But I think it's this one, the upper one. I think
Okay.
the more on the middle third. Yeah,
Okay.
and
So
we also need to remember he tied it with
mm,
a something cloth. Yeah.
yeah. Is that swelling? Is that a swelling?
Look like there is
Um,
swelling also. If
Mm.
I think the tourniquet is probably a few cms below the marking, if I'm not wrong. And
Mm.
yeah,
yeah, looks like it, Anas.
but I cannot see any obvious dermonecrosis surrounding
Mm.
the bite mark, the bite wounds. And of course,
Yeah.
it's been manipulated by multiple prickings and also incising. Yeah.
Yeah, in the incisions.
Yeah.
And we can also take note that immediately, almost like a half an hour after the bite, he already
Mm.
developed the systemic neurotoxicity.
Yeah. So there is a neurotoxicity, right?
Hmm. Yeah.
Okay. Yoshiro, any comments on this picture?
Yeah, I just noticed this type of manipulation, pricking the wound before the hospital can
Yeah.
affect the diagnosis because it's very difficult to identify the bite mark anymore. So
Mm.
yeah, this is a good example.
Yeah, things like this could either worsen the envenoming, right? Because of this, the systemic envenoming could be occurring faster because of the manipulation. Yeah, spreading of the venom. Okay, so can we move on?
Okay, so upon general condition, upon preparing for intubation, noted the patient GCS was full, pupil to bito reactive, and obeying command. So the BP was a bit hypertensive, and otherwise, the thing is normal. And given IM ATT 0.5 ml stat with an IV trauma of 50 mg stat also. So they did reassessment and noted suddenly patient have a bilateral ptosis, dyspnea, and also urticarial rash over the bilateral thigh. So, panelists, what do you think of it now?
This is already IV antivenom already running or not?
Not yet, Prof.
Oh, so the rash is before giving adrenaline, before giving antivenom.
Mm. Another thing, this is a bit unusual. I mean, a bit weird because upon preparing for the patient, suddenly fully conscious. I mean, the CS turned back to be full. Then somehow they still proceeded for intubation. Probably, I assume some breathing effort issue.
Mm-hmm.
And notice, or is it the sequence?
Yeah, there's
Okay.
RSI Anas, because I think it was GCS 15. But initially, if I remember, if I got it right, I think that GCS initially was a bit low. I'm not sure if we can go back to the first one. Yeah,
That was
8.
8.
E1, V2, M5.
8. So intubatable.
Mm.
Yeah, it's 8, right? Yeah.
Okay. Okay.
If I was, the attending, I would still proceed to the to the intubation, and
Mm-hmm.
it's prudent to do the RSI as well because he's got GCS 15, but we need to protect the airway given that he has already been manifesting neurotoxicity. So
Yeah, the bilateral ptosis give away
Mm.
with shortness of breath as well. But the urticarial rash is a bit strange.
Yeah.
Can we see the rash?
Hmm.
Okay, very unusual. Okay. Okay, so what's the plan next? What's the NG tube was inserted? and started on neuropoly antivenom, 10 vials. Okay. So neuropoly is against the neurotoxic snakes. This is typically from Thailand. Neuropolyvalent antivenom for 3 species of neurotoxic snake. Sorry, 4 species of neurotoxic snakes. Okay. Next.
So this is the investigation that was done with an FPC of hemoglobin 14.5. Double white cell count is 8.97 and platelet is 362. They did a renal profile also, and also the coagulation profile as seen below. And there was a liver function test and also creatinine kinase. So
Yeah,
panelists of the
again,
flow.
later on, you need to put the units and also the normal levels. But there's nothing, I don't think there's any, this is just initial blood test, which I think don't play much role. You need to do serial blood tests to see the progress. Okay, next.
So this is the management for the patient. We did keep the current ventilation and make sure the saturated oxygen is above 95%. We will repeat an ABG 1 hour post-intubation and repeat a chest x-ray. Continue the infusion of the antivenom with the intravenous normal saline for 4 pints. And we will give an IV pantoprazole 40 mg with an IV midafentanyl. So to continue monitoring and repeat all the full blood count, CP and CK for 6 hourly and refer anesthesia for ICU admission for this patient.
Okay, so what's next?
So progress for this patient, completed 10 vials of antivenom yesterday and able to extubate the patient the morning after full GCS recovery. So the GCS was full and still ptosis over the bilateral eyes, and the blood pressure was 101/70 supported with a noradrenaline 0.05 mcg per kilo per minute, and the heart rate was 93/50 and respiratory rate was 18. Temperature was afebrile and the saturated oxygen was 96% under nasal prong oxygen. So noted progression of the swelling over the left lower limb up to below the hip. So the pulses were still palpable and there was tender and tense compartments while the CRT was less than 2 seconds. Sensation was still intact, but the pain score at rest, it was no pain, while on movement it was around 2 to 3. So they referred to auto team hospital carpet for co-management of rice therapy and even girth monitoring. So the current plan now is to keep KIV for another dose of antivenom after discussing with the RECS and to continue snakebite charting hourly for this patient.
Okay. So was antivenom indicated again or not? Doesn't look like it. I don't know what is the decision with the orthopedics. Are they going to do fasciotomy?
And no sure for this patient.
Okay, so what's next? Can we see the progress? Okay. So anyway, I'll go back. Just one slide.
Any
Okay,
subsequent blacks for that?
So what do you think, Anas?
Yeah, I'm not sure whether is it a true ptosis or is it a miss. I mean, they thought it's pseudotosis. Probably, I don't know. This one happened. I mean, is it a recurrent or is just a continuation from the prior to the intubations? But I want to know. I mean, any subsequent blood, maybe significant blood findings, the serial blood. And any changes to the local, to the limb?
Yeah, so because you can see just now there was some swelling, and if the swelling is reduced after antivenom or not, and also pain score. But patient is intubated, so difficult to judge the pain. I think
They extubated. I think they extubated.
yeah. So the patient seems to be sort of like responded to the NPAV first dose, and was able to be extubated, right? So GCS recovered to full. But then it says still ptosis bilateral eye. So anything we can do with this ptosis is very unusual, right? Patient already able to breathe, but we still ptosis. So are we going to give antivenom or not for this ptosis, or is there anything else that we can do to consider with
Maybe
this
we can
ptosis?
consider some adjunct like neostigmine probably or atropine.
I was thinking of that.
Yeah.
So we just give some neostigmine to kick out the whatever venom might be there. And it's still within 24 hours, so most likely the antivenom is still in circulation to absorb this the knockout of the venom from the nerve ends. So you can try giving neostigmine as well. Okay, so yeah, we don't have any other history after that, but you want to comment on maybe final comment on the management of this case? Are you agreeing with it or anything unusual that you think?
Yes, I think there are a few factors. I mean, influencing the management of this patient. It begins with the inappropriate first aid. A lot of manipulation done to the bite site, which may worsen the spreads of venoms systemically, and I'm not sure because how the like Emily probably said she wanted to intubate the patient. Yeah, probably because the initial GCS was low, and the SpO2 pun needing high flow oxygen. I mean that's fine with that, but the reassessment post antivenom, that is another issue, Prof. I would say probably before they extubate, they try to off the sedations and reassess serial neurological status, I think. And yeah, again, I would also consider neostigmine and to top up.
Okay, Yoshiro, any last words about this case?
Yes, thank you. I just learned many from this case also. I think the dosage of polyvalent antivenom is relatively higher, I think, compared to the Philippine monovalent antivenom. So it might be another consideration for the potential risk of anaphylaxis. So yeah, anyway, I just thank you very much.
Okay, Kee Vooi,
So
last words? Yeah, go
I'm
ahead.
just I think the swelling, this swelling happened when? Like on what day
Yeah,
of the hospitalization was this?
it's on arrival already. Looks like swollen when they took the
Yeah,
picture.
like it could be like also already beginning cellulitis. That's why there's already the swelling that I mean it's progressing, the swelling. And that's why I'm wondering, did they do a repeat blood CBC, complete blood
Yeah.
count?
So
And
that's why I think in Malaysia we are very adamant to have every 6 hours a serial blood test. So most of the time those initial blood tests will be repeated already, and you might see the significant rise in the white blood cell count if this was a significant envenoming. You see leukocytosis, reactive leukocytosis early in the blood test. In the second blood test, you will see is quite already jumped to maybe in the teens and 20s.
Yeah.
So yeah.
Another thing, Prof. Another thing is maybe the progression of swelling. If they want to, incorporates the role of point of care ultrasound post
Yeah.
advocate post protocol, because we are so stigmatized with compartment syndrome just based on the swelling itself. So if you have the capacity to do ultrasound, maybe you could incorporate that rather than monitoring the gut. We usually don't do that in envenoming.
Yes.
Yep.
Yeah, good point. Good point. Yeah, so ultrasound could help us determine where the swelling is located. Is it in the compartment or is it in the third space outside the compartment? So that will definitely affect our judgment in terms of how to intervene surgically or not, right? Okay, Kee Vooi, last words about this? What do you think?
No, I have no comment, but I have question for panelists, especially for Pro. Let's say
Right.
this one is a banded crab. You
Uh,
give the antivenom like 2 round, not improving. I mean, all of us know the pre-synaptic NMJ disruption, no point giving antivenom. How many
yes.
round you going to try until you say, okay, I should stop already. I already give two round, not
We
improving.
yeah in our guideline we say it's only maximum two.
Two, okay.
Two doses. Two doses meaning that one dose is 5 vials, right? For the Thai Red Cross neuropoly or individual monovalent for crates. But this is not crate because it's swollen and so on.
Yeah.
Yeah, but
I mean,
just
my guess is
if it was, then ours is just two doses. Yeah.
2 round, okay.
Yeah, because we don't see the benefits, extra benefits for keep on giving when the disruption of the NMJ is the issue is not about the venom still there. It's about the destruction of the NMJ itself. Can you unshare? I would like to share for quiz. Okay. Okay, number one, the champion is. Okay, Toxin, please give your details to our secretariat, and so we will give you the prize to you. Okay, thank you.
Doc Cal, the one who had the box jellyfish thing, did he survive?
Unfortunately not. This was a case in Langkawi a few
Oh.
years ago. A tourist from Switzerland got stung
no.
on the chest and collapsed 5 minutes after coming out of the water. CPR on site by fellow tourists until the ambulance arrived. CPR continued, but he was pronounced dead on arrival to hospital. Yeah.
Sad.
Okay.
Thank you to all our panelists, Dr. Anas, Dr. Emelia, Dr. Lu, and Dr. Yoshihiro, as well as our advisor, Prof. Khaldun, for sharing your expert opinions and valuable insight into the clinical management of toxin-related disease throughout today's case discussion.
Now, we would like to present the e-certificate to our panelists as a token of appreciation. So, this is a token of appreciation for Dr. Anas Amri bin Hashim. Let's take a picture to commemorate this moment. All right, thank you for spending your time with us today. Next, this is for Dr. Emelia Santamaria.
Terima
We'll
kasih.
proceed to the next one. Okay, so this is a token of appreciation for Dr. Emelia Santamaria. Let's take a picture together in 3, 2, 1. Okay, thank you for sharing with us today. Next certificate is for our Dr. Kee Vooi. So in 3, 2, 1. All right, thank you, Dr. Kee Vooi. Last but not least, our Dr. Yoshihiro Aoki. Please have a picture with us. In 3, 2, 1. All right, thank you, panelists, once again for the valuable inputs throughout the case discussion. Moving on, we invite our Dr. Anas Amri bin Hashim for the closing speech. Floor is yours again, Doctor.
Okay, first of all, thank you very much again to the organizer for having me this afternoon. And I would like to thank a very great effort by all the committee members, secretariat, moderators, and of course with the guidance from our Prof. Dr. Ahmad Khaldun and the UKM team. I believe I must say that you are very lucky at the medical students years. You are exposed to clinical toxinology. As we all know, like the opening speech by Dr. Aziz earlier, the clinical toxinology is very much, underrated, but I would say it's very, very interesting. So today we have unlearned and relearned and learned new things pertaining to clinical toxicology. And also to all the expert panelists, Dr. Emily, Dr. Kee Vooi, and Dr. Hoshi from the Japan. Thank you very much for all your times and for all your efforts, for all your inputs. Again, thank you very much. Hope this session can be continued for many years ahead. Thank you. Well done.
Terima kasih.
Thank you, Dr. Anas. So let's move on to Farah.
Alright, so before we end our webinar, everyone please turn on your cameras so we can take a group photo together. Everyone, cut camera. Alright, thank you so much, everyone. We have come to the end of our webinar today. And to all participants, please scan this QR code to fill in the feedback form to receive your e-certificate. Okay. You may also click on the link in the text box to fill in the form. And once again, we thank you, all of you, for joining us today. And we hope you have learned something about clinical toxicology today. And please join our SEA City Conference this July. See you in the next episode of Clinical Toxicology. Is it relevant for medical students? Bye-bye. Thank you so much.
Okay, please join us in July, 6 to 8 of July. So we have two exciting pre-conference, mushroom management, mushroom poisoning management, and also clinical research in toxinology. And subsequently on the 7 and 8, we'll be having our conference full of exciting topics, expert speakers, and yeah, a lot of new and updates pertaining to clinical toxicology. So not many seats left for the conference, but we still have plenty for the pre-conference.
I think as of today, we only have 12 seats left.
Yeah, I think it's less than 10 already for the conference.
Oh, okay, less than 10 already.
But we still have some for the pre-conference. Emily, are you coming?
I wish, Doc. I'll message you.
Kee
I'm
Vooi,
missing all of you now.
come join us.
I can't because July have something going on. Sorry about that.
I see.
But my
I see.
colleague is joining. My colleague is joining.
Yeah. We had some registration from Singapore. Thank you. Do help us promote the events.
Sure. We actually share in our talks group already. Yeah.
Oh,
Oh,
okay,
great.
great.
Thanks.
Thank
Thank
you.
you.
Thank you.